yes, thank you very much for the introductions and the invitation to come and speak to a sort of a very wide audience, a knowledgeable audience on management of SARS-CoV-2 waste, which is generated from different environments. I'm Thomas Pottage. I work for Public Health England in the UK. I work on the Porton Down site in the south of England. I've worked for Public Health England for over 15 years now in the biosafety, air and water microbiology group, where we do a lot of, obviously the name implies, sort of biosafety work. So we look at looking at the mechanisms and the engineering behind biosafety, so things like cabinets or construction of laboratories, but also we deal with a lot with like waste management and decontamination remediation of sites, and also sort of environmental sampling. So within this sort of presentation, I'm going to touch on, is it moving on? Sorry, it's not moving on for some reason. Okay, cool. Yeah, I'm going to touch on sort of what the current issue is in terms of SARS-CoV-2 and waste. Then we're going to look at the actual virus in the environment and why does this matter towards waste and how this can affect people. And then, as John mentioned, I'm going to sort of have the second part of the presentation, which is going to look at waste management in more specific environments. So sort of looking at healthcare, laboratories, residential and other areas. And then throughout this presentation, I've put quite a few references in. And what I've done at the end, the last few slides, is I've actually put the references in there for people to be able to sort of to use when you get the presentation out. So obviously, as a background, SARS-CoV-2 has caused a pandemic, and this has led to unprecedented levels of waste generation. And this is from sort of not only just from PPE, although as I mentioned in sort of healthcare settings and the wider public as well. Obviously, more people are wearing masks, people are wearing gloves. And obviously in the healthcare, there's a lot more people who are requiring looking after by healthcare staff who are all having to wear higher levels of PPE due to the nature of the virus. But there's also sort of waste in terms of chemical waste as well. We're not just looking at biological, although I'll be focusing it here, but obviously there's a lot more surfaces which are being cleaned. People are using more hand gels. So actually there's a risk to the environment for extra chemicals being sort of pollutant agents as well. And it's not always clear how the waste should be dealt with. And we'll try and address that in this presentation. And obviously, with waste which can be maybe segregated, can lead to some of the waste streams being overloaded. So just a bit of background about the virus, and I won't go on to this, although probably the thing to remember here is it's a lipid envelope virus, which we'll touch on later on. And obviously it's a risk group 3 agent as well, although there's some derogation when handling it in the laboratory, depending on the risk assessments which are performed. But it's thought to be transmitted through aerosol and fomite routes. Just move that away. Cool. So just looking at the transmission route, it's quite important as it does have a bearing on the hazard from the waste. Obviously, with the aerosol risk, there is a potential for re-aerosolization from waste, from contaminated waste, but there's also so probably the majority of the waste will be a risk or hazard from the fomite transfer from contaminated waste and the handling of that waste. And the transmission route of the virus is in a number of principal ways. So we have the inhalation of respirable droplets. So we're looking at droplets really that are sort of lower, that are smaller than 10 microns, will actually get into the nasopharynx or lower than nasopharynx into the thoracic region, and then into the alveoli as well. And then those won't actually be respired out. So we're actually hitting the mucosal membrane. Then we have some sprayborne. So obviously the larger droplets, sort of upwards of 10 microns up to a sort of about 100, 200 microns, which will actually more sort of ballistic droplets. So they are larger, and if they obviously people sneeze or cough, and they're likely to actually sort of deposit and contact the mucosal membranes, which can cause infection that way. But they also have deposition from these larger particles as well. So obviously, the larger the particle, the more or the quicker it more deposits or will deposit onto surfaces. And then we get the fomite risk through touching. So here, obviously, in this graphic, you can see a mobile phone being passed, and obviously if someone has contaminated that and is being picked by someone else or touched by someone else, there's a risk to that other individual. But there's also things like desks or chairs potentially, and door handles, so anything really which could be contaminated and contacted by someone else. And there's quite a bit of work going on at the moment to look at this mechanism of transfer and just see sort of what the risks are from it. But the risks will actually vary according to level of PPE which people are using. Obviously, wearing masks will stop or stop the majority of spray-borne droplets and some respirable particles. But also, if we're further away from someone, so if we're over 2 meters, then the sort of respirable droplets or respirable aerosol, sorry, will actually decrease in concentration before they're actually sort of contacting someone else. But also things like ventilation systems in rooms, and also the time after sort of the events happened as well, because obviously natural deposition will occur as well. So this is just a graphic taken from Sebek's paper, which shows in a bit of detail the level of viral genome production in an infected patient during the different stages of the infection. And actually, we can see during the pre-symptomatic phase, the viral genomic copy number will actually increase sort of exponentially to a point where after up to sort of three or 4 days, we're getting the peak viral load. But actually then that actually drops off. So once people actually get to the point where they're actually more seriously ill and admitted to hospital, actually the viral loading actually starts to reduce considerably. So actually, what level of viral loading will there be in a waste which is actually produced by people within hospitals and when they're actually severely ill? And this is something we've been into a number of hospitals and healthcare settings within the UK, and we've performed a lot of aerosol sampling and surface sampling. And the levels actually of viral genomes are actually, or genome copy numbers are actually quite low on surfaces if we can find detected at all. And I'll touch on this in a minute. So what we can actually look at is the viral survival in the air or persistence in the air. As I mentioned, it's not really a true waste issue, but there is a risk from re-aerosolization. If, say, a waste bag was to open or someone's handling waste, and there is potential for re-aerosolization of any particles on the surface. But survival in the air is often the main precursor of how we determine what PPE or RPE we use. Obviously, as masks are a very good example, but also sort of if we're looking at that sort of ballistic particles during things like aerosol generating procedures, so bronchoscopies or chest manipulations or CPR, then actually we're going to maybe need a higher level of PPE and more people will need PPE in that room. So actually we're going to generate more waste during these processes or after these processes. But as I mentioned, through the aerosol sampling around patients, through intubation and CPAP as well, then actually we're not finding that much or that many viable virus particles in the air around patients. But we are finding sort of RNA. So actually, does this indicate that there's no viable virus, and actually people are just exuding RNA rather than those viable virus particles? But actually, for the survival in the air, the US Department of Homeland Security has produced a calculator, and I've included a link here to the website, and you can go onto it. And with 3 main parameters, you can actually show you the sort of stability or persistence of that virus in the air, and it will give you the sort of the half-life, so the time when 50% will be inactivated, 90%, so when 10% will still remain viable, or 99%. And you can play around with the temperature and the humidity, so you can create different environments there and see what the stability is like for the virus in different environmental conditions. So if we look at survival on surfaces, there's been quite a lot of work completed, and Kaslov and Riddle have completed work, and they found that SARS-CoV-2 persists on different surfaces, including PPE, for up to sort of 14 to 28 days before it reduces down to undetectable levels, and this is via plaque assay. So they're looking specifically for viable virus. But these studies, use quite high concentrations of the virus in the initial inoculum on the surfaces, and whether that actually represents what would be found on a surface is sort of up for debate. And we actually, within the biosafety group, as Peyton et al., we found that in our studies, we are finding that SARS-CoV-2 was surviving best on hydrophobic and non-porous surfaces. And it survived for detectable for up to 7 days. And we looked at plaque assaying as well. So we looked at the viability of the virus over the course of those 7 days. But we found that it is actually dependent on the medium which it's presented in. So if you have a high salt and high proteinaceous medium which the virus comes from, then actually that gives a higher persistence than actually if you just have it straight from water or something like that. But also on the surface, so we found that porous surfaces didn't actually, or the virus didn't persist for as long on porous surfaces as it did for non-porous surfaces. And we think that actually gets absorbed into the fibers and either doesn't get released or it basically is dried a bit more. So basically you get more inactivation through desiccation. But also the survival was found by Birikov that actually with an increase in temperature, there was a significant decrease in persistence, and also with an increase in humidity as well of the surrounding or the air, then actually you've got a much shorter sort of half-life with an increase in humidity. But the work we did, we also looked at high and low loading of these surfaces, and we found that the inactivation rate is actually independent of concentration. So we looked at sort of loading at 10 to the 5 and at 10 to the 3 on the surfaces, and we found that inactivation rate was the same for stainless steel. So this is just a couple of graphs taken from Peyton's paper, and just to demonstrate that actually inactivation on porous surfaces is a lot quicker than on non-porous surfaces. On the left, we have stainless steel, and the orange dots are the plaque assay results. So we're looking at viable virus, and actually the blue, at the same time, we looked at genome copies from the inoculum, and what we can see is the inactivation of the virus, or the viability of the virus decreased a lot quicker than actually the RNA was decreased. And you can see from cotton, we actually had a much steeper decrease in viability compared to the stainless steel. But actually the RNA didn't decrease in that same amount. So we can sort of assume there that the cotton is affecting the viability of the virus. And we think this is through the desiccation process. So if we look at some of the work completed looking at environmental contamination levels, now, as I mentioned, the lab studies use artificially high levels. So we're looking at sort of 10 to the 5, 10 to the 6 plaque forming units per 10 microliter droplet, per 50 microliter droplet. And actually that's very high in comparative to what might be seen in the environment and actually what is being found in the environment as well. So a lot of the environmental surface sampling work or aerosol work is actually using RT-PCR, so looking at the RNA of the virus, but actually not looking at the viable virus, because the initial work completed shows that there is very little viable virus detected on the surfaces. So does this show that the virus is inactivated very quickly on the surfaces, and just the RNA persists, or is not much viable virus actually produced from people and goes onto the surfaces. And what we can see is the CT value is mainly above 32 for the PCR assays that are being completed. And this shows that it's actually sort of highly unlikely that levels will be, or viable virus will be detected on the surfaces. And the work that we completed looking at using our different concentration inoculums to start with showed that actually the levels which might be present on surfaces would be inactivated within 48 hours of viable virus anyway. So initially there was an uncertainty split between aerosol and fomite transmission, but a lot of the data now is indicating that surface transmission is less likely. So aerosol transmission route would be the primary route of transmission for the virus. And actually a quantitative microbial risk assessment, so I didn't want to put that in there, completed through work looked at by the CDC in America, actually showed that there was a sort of a 1 in 10,000 chance of causing infection from a contaminated surface. So it's actually quite low. And actually that risk will decrease even further on outdoor surfaces. So if things are open to either UV light or outdoor open air factor as well. And also, as I mentioned before, as increasing temperatures, increasing humidities, that viable virus will actually desiccate and be inactivated a lot quicker. So what does this mean? Obviously, that work sort of goes to show, and the previous environmental sampling in the hospital environments and healthcare environments shows that actually that surfaces are unlikely to be contaminated with large numbers of SARS-CoV-2 virions, and the virus is rapidly inactivated. And being a lipid envelope virus, we can see on the right here, we have the hierarchy of disinfection, and we can see at the top, we obviously have the most resistant organisms and the most susceptible at the bottom, and lipid envelope viruses are right at the bottom, and are sort of the easiest to disinfect and inactivate. But what has been shown is actually there can be difficulties in activating this virus when it is associated with high levels of protein or salt, so something which might be bodily fluid. So we have to really take that into account if we're having waste generated in those environments. And obviously the use of RPE will decrease the surface contamination, and hand hygiene regime will help to reduce that infection risk. And this will help to alleviate the sort of likelihood of transmission in the general environment. But there are obviously environments where waste can be contaminated, and it needs to be dealt with effectively to reduce that risk of infection, but also to alleviate the pressures on the existing waste streams as well. So talk about sort of waste separation, segregation in a minute. But John, yeah, I think that's probably good to then have our next set of polls, I think.
Okay, thanks, Thomas. Yeah, interesting to understand the viability of the virus. And in the early days, we were much more concerned about this than we are now. It's obviously the science has grown. So let's launch the next poll. So the next poll actually is about the categories of waste that you find that are of most concern. So I've given you two options. So what I'm inviting you to do in a moment will be to select the first and second type of most problematic waste. So let me just launch the poll and you'll see what I mean. So WHO guidance identifies 6 types of healthcare waste. Please select the most problematic during COVID-19. And the second question is the second most problematic. So we're asking you for number 1 and number 2. So we've got infectious waste, sharps, needles and so on, syringes, pathological waste, samples, pharmaceutical, cytotoxic waste, chemical waste, or unlikely, I guess, radiological waste. But please select the ones which you feel have been most problematic for you in your experience, and we'll have a look at that. And then the second one will be your second choice, if you like. So So Tom, traditional now is for you to give a forecast on what will be number 1 and number 2. So it's all on you.
I think based on maybe on the attendees and on obviously what we're aiming this on, I'd probably say infectious waste might be the top one.
Being a bit cagey now.
Yeah.
Okay.
And then 2, oh no, it's the same one.
Yeah,
I think it would be infectious and then maybe sharps and pathological, I think.
Okay, all right. Well, you have it's called spread betting, I think.
Yeah. I'm an each way type of better.
You win whatever happens.
Yeah.
Okay. But I mean, in the UK, what do you think in the UK, from a UK perspective, what do you think has been the most difficult? Has it been the infectious waste? I mean, do you think?
I think, yeah, it has, but also I think it's what's perceived as infectious waste. And I think in terms of obviously one of the issues which I'll touch on is the sort of domestic waste, especially since people are self-isolating a lot more. Obviously, we'll come into it without giving the sort of second half of the presentation away, but yeah, I think it's that perceived infectious waste. And actually what you do for things like the tourism industry and sort of workplaces, obviously there's a lot of masks being used in workplaces, and non things like supermarkets and shops and stuff, and actually what do people do with the waste there as well? So actually, how do you deal with that?
Well, we'll talk about that. People with disposable tissues that they're throwing away and masks and so on. It'd be interesting. We'll talk about that a little bit later, maybe. Okay, let me end the poll. Lots of votes here, and share the results with you. So yeah, I mean, given what you said, you were right, of course. Infectious waste has come up as number 1, and then a mixture really for number 2. Tiny one person selected radiological waste, but quite a bit of pathological waste, sharps. Yeah, a bit of an even spread there. Not so much on the chemical waste. I was intrigued by that. I was just what I had in mind with the question was obviously a large amount of chemicals have to be used to inactivate the waste, and does that represent a further problem later on down the line when you've got to then do something with excess chemicals or any residues that results? But we can think about that in a bit later. Well, thanks very much for answering that poll, everybody. I've got I don't know, Tom, if we should go now. Should I just flag up the areas of concern that they might have had? Yeah, let's try that. Another quick poll, just a short one this time. So I'll launch it now quickly, everybody. So what's the area with the biggest waste concerns for SARS-CoV-2 in your country? Is it healthcare, labs, workplace, or tourism? The categories that Tom has just mentioned. Actually, just give us a flavour. See what comes up. Prediction, Tom? You've only got 4 choices. I only want 1 this time.
Healthcare.
Okay. I think you might be right, actually. I can see the results coming in now. So I can put a bet on it because I know the result of it. So yeah. Okay, so a few more coming in. I'll give everybody a couple of minutes. I hope everybody appreciates these polls. They're useful for us, but I do hope that people enjoy participating too. It brings the webinar to life. 70% voting. I'll give you another 30 seconds just in case anybody else wants to add to that. It's pretty overwhelming, really, the results from what I can see. Okay, the voting's slowing down now, so I think I'll end it quickly so Tom can move on. And yeah, surprise, surprise. There you go, healthcare. So yeah, spot on, Tom. Good for that. But interesting, you will talk a little bit about workplace and tourism a little bit later on, but obviously the main concern is healthcare waste, obvious reasons. Okay, look, let's stop this now. We've got a couple of more polls later on, but we'll do that at the end. Tom, so back to you.
Cool. Thank you very much, John. Yeah, so now I'm going to start speaking about sort of more specific environments and looking at the actual waste management of the waste in those areas. And I've taken a lot of this work from sort of experiences here, but also other governmental sites. So looking at sort of the UK government, US CDC, the World Health Organization, and the European Centers for the Disease Prevention and Control as well. And again, referenced a lot of this work in the last couple of slides as well. So you can see where this has all been taken from. So what do we need to do with waste? And I think it's really important that rather than sort of going just to follow the usual lines of your waste management processes, I think you need to sort of start risk assessing the hazard from that waste and the likelihood from that contamination. And that was sort of really what I was trying to get out with from the first part of the presentation, to show you that actually it's very useful to sort of do a bit of research and look into the potential for contamination of that bits of waste from different areas, and what's the likelihood of sort of transmission of that contamination onwards as well. And you can use this obviously as by guidance documents from country guidance or governmental guidance documents, but also scientific literature. And it can really help to reduce the strain and the volumes of waste on the more intensive handling or waste handling streams. So if we're looking at inactivation of that waste prior to disposal, then obviously that can be a big backlog there as well, where we can have lots of waste which if wrongly identified as hazardous, can be really cause a lot of procedural difficulties to actually be inactivated. So we're going to focus quickly on the healthcare side, and actually going from the NHS England websites and the CDC, and there's a couple of other documents as well. They all state that actually infectious medical waste produced from healthcare facilities with COVID-19 patients should be treated like any other infectious clinical waste. Obviously, SARS-CoV-2 is an infectious agent that has a group 3, but there are other hazard group 3 agents which are infecting people as well. And actually, there should be waste streams set up for this in terms of identification, separation, and treatment of the waste. And actually, this virus is no different than that. It's just the amount of waste which is actually being generated at the moment due to sort of PPE and RPE. And also obviously chemical treatments as well. If there's a lot of chemicals which are being used for the disinfection of surfaces or equipment, then this can actually produce a bit of a strain on the waste management side. But the waste should be handled through existing waste streams, and these waste streams should have segregation, transport, storage, and sort of waste treatment should be in place already. So in terms of segregation, we want to make sure that our general waste, so uncontaminated waste, should be separated from infectious waste. So obviously, if we have we can try and use different specific waste containers, and color coding and labeling to make sure that we identify the different types of waste, and then we can actually separate and segregate waste at source, which can make it a lot easier, rather than we're not trying to separate it downstream, where we'd actually then have mixed waste, and we'll have to treat it all as infectious waste. And this really helps to alleviate the downstream processing and the downstream waste management. So looking at things like transport, if we have infectious waste, we need to make sure that we have designated routes for that waste. We collect it at designated times. So actually, are we looking at if we're in a busy hospital or lab, are we actually having routes which might not be as populated, so we're not exposing public or non-vaccinated people potentially to that waste if there is an accident. But also we can do it out of hours, so we can actually sort of move that waste without having any fear of any interactions with other people. We need to make sure for internal waste transport that again the trolleys are labelled, or the containers we're using are labelled with a hazard sign and an identifier. They really need to be sort of watertight, so if there is a leakage from any of the waste bags, it's not going to sort of trail off down the corridor, but also it means we can decontaminate them as well effectively. And we need to make sure we're not transporting infectious waste along with non-infectious waste, just in case there is a leakage or a bag splits open, so we're not actually going to have a mixed waste situation there as well. And we need to make sure they're easy to move as well. We don't want to obviously have big bins which require 2 or 3 people to push, as that can be really difficult to actually sort of manipulate around corridors. And if there's no formal guidance on off-site transport, then you can actually use the UN recommendations on transport of dangerous goods and model regulations. And I've included the link here, which you'll be able to click on in the presentation. So also we need to think about waste storage. It's obviously not always possible to inactivate the waste at the point of generation. But we want to try and make sure that if we are storing waste before we then take it off to an inactivation site, or if it's being collected by external contractors, then we need to make sure we limit that storage time for as much as possible. And actually in sort of temperate climates, it's identified that should only be up to 72 hours in the winter and 48 hours in the summer, but in warmer climates we want to reduce that time down as well, so 48 hours in the cool seasons and 24 hours in warm seasons. Obviously we don't want to keep that waste hanging around or being present for longer than it needs to be. In the waste storage areas, need to make sure that the floors and walls are sealed or tiled, and again this means that we can contain any leakages, but also means that we can adequately decontaminate that space as well, as we need to keep on doing, because bags do break, people overfill them, or they don't tie the knot up as much as possible, and then things will leak out occasionally. We might try to have managed access to this area as well, so we want to try and make sure that we're restricting any access to it, so it's only really the people that are trained to go in and actually know how to deal with the waste which will be able to go in there. And again, we need to have correct labelling, and here you can see a waste label taken from a UK hospital, so you can see where the waste is labelled, or how the storage area is labelled, sorry. So if we're inactivating, we really need to, ideally should be being completed on site prior to safe terminal disposal. And the best methodologies are high temperature, so things like autoclaving or hydroclaving, and obviously as well incineration as well is sort of the end point for the waste. But we need to make sure that our processes are validated as well, obviously, and our equipment is maintained correctly. And we can do that either by, in terms of high temperatures, we can use thermocouples and sort of making sure the temperature probes are reading the correct temperatures, or we can use sort of biological indicators, which can be put into the processes, and actually sort of then identified to see if those surrogate agents are inactivated. And this is really important because obviously if we're not inactivating our waste here, then we're potentially releasing it downstream for uninactivated waste or live waste, and that can actually obviously cause infections into people downstream. And we also need to make sure we protect the workers who are handling this waste. So in terms of sort of SARS-CoV-2 and other infectious agents which might be aerosolized, we need to make sure they have correct RPE, but also, as I mentioned, we need to make sure we stop any of that sort of those large particles contacting their mucosal membranes. So we need to think about things like face shielding or face coverings, so goggles or visors, And then also we need to think about stopping any splashes or contact onto hands. So we look at things like gloves and long sleeve gowns. And obviously if we're handling hot items which might come out of an autoclave or a hydroclave, then we need to make sure we have those thermal gloves, because there's other risks associated as well as just the infectious agents. And rubber soled boots, ideally puncture resistant, because obviously if we are autoclaving needles or incinerating needles, they might not be fully destroyed, and there is a puncture risk there as well. So a lot of the facilities, you might not have your own areas of inactivation or ability to inactivate waste on site. So waste contractors can be used, but we need to make sure they're fully licensed according to your government regulations. And also that process is auditable and traceable as well. So there can be regular inspections by the waste producers as well, to make sure that we fully understand what treatment processes are being used, and actually the sort of safety steps and being used by these waste contractors as well. So we can sort of have a look, and we can audit them ourselves to make sure that the waste is actually being disposed of and handled correctly, because obviously a lot of the time it will come back onto the waste generator rather than the waste contractor if there is an issue. So moving on to laboratories. Now, obviously, there's a couple of different types of laboratory models, and we can either have diagnostic models where we're looking at low volumes for each sample and low concentrations of infectious agent within it. But actually, there can be other pathogens within that sample. So obviously, if someone's presenting with a potential chest infection, and you process the sample and you find out it's not SARS-CoV-2, then actually it's going to be another infectious agent, which could be obviously a high risk to those people or the workers. So we need to something like TB. So we need to actually think about the waste is not only just from SARS-CoV-2 here again. And in the research environment, we're obviously generating high volumes or propagating high volumes and high concentrations of SARS-CoV-2, and that would solely be SARS-CoV-2 for work at, say, we're looking at the aerosol stability or the surface survival as the studies we've completed already. And usually we'll have smaller number of samples, but obviously they will be at higher concentration. So the waste is slightly different. And sort of the samples need to be handled slightly differently. So saying in biosafety level 3 laboratories, all the work should be undertaken within a microbial safety cabinet. But in terms of the diagnostic laboratory, once those samples have been inactivated, and that can actually be completed in a class 2 cabinet, depending on the risk assessment and the procedures and the government approval, then the samples can be handled outside of that safety cabinet. And then there's sort of, as usual in sort of both laboratories, but generally in sort of the research laboratory, we always look at disinfection at each step. So we call it disinfection at source. We want to make sure that we're reducing that risk at each step where we're handling those agents. And as I mentioned, in the diagnostic laboratory, you need to be careful that we're not just looking to inactivate SARS-CoV-2. So we use a validated process for other agents that might be present in that sample. So we're not exposing our workers to potentially other infectious agents. So in terms of inactivation for laboratory waste, again, if we're handling an infectious agent, SARS-CoV-2 is no different than any other infectious agent, and we should already have our waste streams in place. Obviously, again, we might be generating more samples at the moment, so we need to think about what we'll be doing with those samples and more consumables as well. So we need to think about the downstream processing and having assessment of what we need to do with that waste. Now, waste should be stored in the containment laboratory until it's ready to go to in our inactivation process, and it's only transported to the autoclave when it's available for use if it's outside of the laboratory. Can also use incineration as an appropriate mechanism for the inactivation of the waste. But again, we need to make sure our packaging and transport are appropriate, so we're not going to have any leakages, but also we're segregate, or we're identified our waste between sort of hazard group 3 agents, which will need sort of an additional decontamination process, sort of should ideally in the laboratory prior to actually removal from the laboratory or the facility, as opposed to sort of hazard group 2 agents. So I'm going to move slightly away, obviously, from the healthcare and laboratories, and look at the residential waste and management of that waste. So actually, for people not self-isolating, obviously the normal source separation and treatment and waste management processes should continue. But there is actually likely to be either an increase in plastics or non-recyclables, and then from this waste, which can actually increase the amount of waste generated from residential areas. So for things like non-recyclables, we're looking at face masks, but in things like plastics, it could be plastic bottles from hand gel or liquid chemicals, which are produced in sort of surface decontamination in sort of residential area. And as well, there's potentially an increase in the chemicals. So obviously we need to think about waste treatment in terms of water waste as well. So there could be an increase of chemicals that are being poured down the drain, and actually will that affect water treatment processing plants? But also that anything that goes to landfill as well, or municipal dumps, there could be more chemicals in that waste, which could leak out and cause issues if it gets into the water table at all. And also, is there going to be a disruption in municipal or private collection services? Obviously, either if people are self-isolating, or if there's an issue because of overloading of these facilities or these processes, and actually might need to have some alternatives in play. Otherwise, there could be a build-up in the waste, which obviously is going to be a bad thing and needs to be dealt with as soon as possible. For those self-isolating households, and this is some of the guidance taken from the UK government site. If people are self-isolating and they are positive, then the waste generated in the home can be disposed of by the normal waste stream still. So it doesn't need to be treated or handled any differently by the waste management operatives. Actually, what needs to be done slightly differently is people within the residential areas. And actually, what people are told is they should not undertake any recycling, as obviously everything in that household could be contaminated. So everything will have to go to normal municipal waste, but the waste should be double bagged. So actually there's less chance of it splitting open and the waste operatives contacting it, or splitting open in the municipal waste site as well. And also, as sort of in the laboratory and the healthcare facilities, shouldn't overfill the bags, so they should be filled up to 70% maximum. And then also, what's told for people is to keep their waste bags for at least 72 hours before they put them out to collection. And as you've seen before from the work that we've done and other people, that SARS-CoV-2 is sort of is inactivated on surfaces with time. So the idea here is actually the level of contamination on those waste bags should be at a low level, which would mean that there would be inactivation of that SARS-CoV-2 on the surfaces within 40 hours. But actually that 72 hours just gives a little bit of a buffer. So we're not exposing those waste collection operatives to any contaminant or any well, we're trying to reduce it as much as possible if there's any SARS-CoV-2 on the surfaces, and it should be inactivated within that time. I also need to keep secure from pests, and so the bags aren't ripped open, but also scavengers as well. So there's been cases obviously of people scavenging through household waste, but also municipal waste, looking for recyclables, but also items which shouldn't be recycled, such as face masks, which they're actually then being resold. And obviously this is quite a high infection risk. If you're putting a mask on from someone else which hasn't been decontaminated, there's a chance that they could have SARS-CoV-2 and pass it on to you. And for laundry, again, the same, after self-isolation is over, should wait at least, the person should wait at least 72 hours before taking their laundry to a laundrette or dry cleaner. And this is again to sort of allow that inactivation of any SARS-CoV-2 virus on the surfaces there. So sort of looking at other areas as well. Obviously, it's not, with a lot of people going back to a lot of children going back to school or workplaces, and sort of tourist industry reopening as well. There are going to be a lot of extra waste generated here from PPE, but also from lateral flow devices. And then the recommendations are that the waste here or the sort of PPE or the lateral flow device should only be handled by the user or the designated person undertaking testing. So within the UK, some of the facilities and schools will have a single person who does the lateral flow devices. So that will be the only person that should contact those and actually dispose of those. So we're trying to limit the number of people again who are contacting any potential infectious material. And then obviously hand hygiene is very important, and a hand should be washed and disinfected after handling any of this waste. But the waste should be disposed of in the normal route, so normal waste bins at work, or the waste can be taken home in terms of a mask. If you take that mask home and dispose of it in your own domestic household waste, and it shouldn't be recycled. But there might be a need for an increase in number of bins, and this has been found in a number of institutes and facilities, that actually the number of bins around a facility or institute have had to be increased, because they're finding that these bins are being filled up a lot quicker. Lateral flow device. This is a picture of mine this morning. So fortunately, there's only one line on it. Otherwise, I might be spluttering a bit more. But actually, this is something which can be or the outer packaging. Obviously, there's a lot of cardboard, so that can actually be recycled, because again, it should only be handled by one person. So we can actually look at recycling that. But the LFDs themselves and the swabs can't be put into the recycling streams. Obviously, this is quite a waste in terms of plastic. But there is a potential that they could be contaminated, so these need to just be treated. In sort of a healthcare facility, they can be coded as offensive non-hazardous waste, but actually for non-healthcare facilities, they can be managed alongside other waste in terms of black bags. But if you are worried, you can discuss this with your waste contractor or your sort of government contacts in terms of the environmental departments or waste management departments there. So some issues in terms of improper waste handling. Obviously, improper waste handling can cause an infection risk to quite a wide selection of people, a wide number of people. And obviously with sort of a lot more waste being generated, then there might be a case for illegal waste operating or waste operatives collecting waste and then performing dumping. So this is one of the reasons why you need to really check what your external waste contractor will do with the waste and make sure they have the proper licenses for your country. And as mentioned, scavenging, we need to make sure that scavenging obviously does happen in countries, but also we need to try and make sure that the potential from scavenging from infectious waste is reduced or eliminated at all. But there was also, as I mentioned in sort of the introductions, there can be an issue from environmental issues from pollution. So this is not just the chemicals used, but also the masks which are ending up in the sea and affecting wildlife, which obviously there's quite a few pictures about, but also chemical pollution from maybe open burning or incomplete burning. And incineration can also cause issues as well, because there's obviously a lot of plastics within this waste, which needs to be dealt with appropriately. So in conclusion, as I sort of demonstrated, that SARS-CoV-2 doesn't remain viable on surface for long periods of time at the level that's found in the environment and environmental contamination and the levels which should be found in sort of waste. And transmission by fomites is a reduced risk in the environment. And we can also further reduce the risk of any infections by using RPE and PPE correctly. And also that's actually waste segregation will help to reduce the volume that requires the intensive treatment. And really that we're just using the appropriate waste streams which are already in place in terms of facilities that are dealing with infectious waste. So we can actually help reduce that strain on those waste management streams. So thank you very much for listening. And obviously, I think we're going to have a sort of a question and answer session now, or discussion session.
Yeah.
And then
thanks, Tom. Yeah, no, sorry to interrupt there. Yeah, no, what we're going to do now, I've got 2 quick polls to look at the current arrangements in the various countries, Tom, and then we'll have a panel discussion. We've got 2, 3, 4 questions that have come through, and I'll throw those open to the panel at the end of the polls. I just wanted to get a feel from the delegates, the kind of arrangements that they have currently in place for the management of SARS-CoV-2. Let me just launch the poll, you'll see what I mean. We'll just do this quickly. So how is, for some reason this isn't printing up very well, but how is your SARS-CoV-2 waste currently managed? Physical treatment on site, i.e. incineration or autoclave, collection and inactivation by an external contractor, collection and disposal by an external contractor, or municipal collection, local authority collection and disposal. So, Tom, I'm going to let you off the hook here. I'm not going to ask you what the prediction is for this one, but I mean, typically PHE. What do you do with SARS-CoV-2 waste? So, what's your prime inactivation route, shall we say?
So we have autoclaving on site. And then that waste is then returned to a laboratory and bagged up, and then it's taken off for incineration. So we have a chemical inactivation at source. So obviously if we have any cultures, we'll add either sodium hypochlorite or Virkon to those cultures or propagated virus to actually inactivate them, and then that will be then put into our waste stream, which will then go for autoclaving, and then the waste will be incinerated after that. So we have a sort of a multiple step approach.
Okay, great. Actually, you mentioned Virkon. We've got a question about that. I'll come back to that in a moment. So one of our participants has asked about that, and I'll put that up shortly. But yeah, okay. So let's see what the delegates have said. Yeah. Majority have gone for incineration, but there are a few that are collected and dealt with by external contractors. So, you know, the issues about long-term disposal are still there, segregation, transportation, all the things that we talked about are still present. Thanks very much for doing that. And then the final one, just really quickly, is what do you think are the potential vulnerabilities, if you like? What are your biggest concerns with waste contaminated with SARS-CoV-2? Is it incomplete inactivation, staff handling waste, not being appropriate, not wearing appropriate PPE, and therefore being infected themselves from waste, overproduction of waste and no facilities to handle waste, illegal dumping, or scavenging of dump sites? So have a think about that. Tom, is there any evidence of, I'm going to call it reverse zoonosis, but of infectious waste being scavenged by rodents, vermin of other sorts, and then reinserting itself back into the human chain? I mean, has any work been done on
that? No, I'm not aware of anything that's been looking at that. I know there's been some work that's looked at potential antibodies in some animals, in sort of wild animals, but I'm not sure if there's been any work looking, or epidemiological work looking at reinfection from sort of scavenging pests.
Interesting.
I think there could be an issue from the spread of the waste, though. Obviously, if an animal was to drag a bag around and split it open, I think that's probably more of a risk than sort of them becoming that spread.
Yeah, I guess so, and I guess the risk is relatively low because they're not they're not the sort of things that you want in your home anyway, or anyone else for that matter. But yeah, I just wondered. I thought I'd just ask that while the questions were coming in. We've got a few answers coming in. It looks as though we're heading towards actually overproduction of waste. Well, no surprise there, and then limited facilities to handle waste. That's come up in one of the other questions that I'll play back to you in a moment. Let me just end this quickly. 2 minutes done. So that's the overall picture. Quite an even spread, really. I mean, incomplete inactivation. Interesting. People handling waste, not wearing appropriate PPE, and then being infected. I mean, that's a potential risk. I mean, I was surprised at the 72-hour timescale for handling stuff to a laundry. I mean, that must be interesting for hotels and hospitality environments where there's a potential there. Overproduction of waste, illegal dumping of waste to some extent, and scavenging also. So there we go. Sorry, I didn't press the button then, but there's the results. I won't go through them all again. Yeah, there we go. Equal first, staff handling and overproduction, and the others, but all of them of concern, obviously. So quite an interesting picture. Great. Okay, let me stop sharing that. I'd like to turn to some of the questions, and I'll throw it open to any of the panelists can join in. Tom, take the lead on this, but if Christopher or the others want to join in, please feel free. So in the chat, we had a question about waste, in liquid waste, for example, wastewater. So we know, I mean, actually some countries are sampling wastewater for the, for hotspots, to identify hotspots with SARS-CoV-2. In fact, infectious waste or, levels of infection in wastewater. I mean, one of the suggestions is that bleach could be used to disinfect that, but of course, I guess the dilution level will be quite high. So yeah, any thoughts on that, Tom?
Yeah. So in terms of the first question, I think that obviously, as you mentioned, there's been a lot of work and there's some pilot studies going on at the moment looking at the identification or sampling of wastewater to sort of identify hotspots around the country in the UK, or I know other European countries are doing it as well. But I think from the work they've completed, they've or I don't think they've ever identified or isolated any viable virus. It's all been RNA based, so it's all been molecular technique based. So in terms of SARS-CoV-2 and wastewater, I think it's not so much of an issue. And again, you have the dilution effect there as well. Obviously, if someone's contaminating producing contaminated wastewater, then actually you'll have a sort of a very high dilution effect going into that water, the major water area which that wastewater is going into. Obviously, if there is treatment facilities, they are designed to, or wastewater treatment facilities in terms of sewage, then, or in a facility, then they are designed to inactivate those any infectious agents that should be present in that water already. Okay, so I think you have a sort of combination there.
Yeah, and in terms of concentration of bleach, I mean, you only need quite a mild concentration, don't you, of bleach to inactivate the virus? I mean, 10% of hypochlorite or something. I don't know what the actual figure would be.
Yeah, I think it's for non-healthcare settings, it's recommended by the WHO. It's 0.1% bleach, so it's quite a low concentration because obviously, as I mentioned, SARS-CoV-2 is a lipid envelope virus, so it is inactivated very, very easily. But again, as you mentioned, if you're disposing of contaminated wastewater, and you're going to have a dilution effect there as well. So actually, chemical treatment, unless you have a physical container of it, is probably a reduced or an option which isn't going to be very well usable if you're trying to sort of pour bleach down a drain or something like that to try and inactivate it.
Okay, great. Well, thanks for that. Let's have a look at two specific questions that have come in via the question and answer chat line. So one from Chibui in Vietnam. Is there any data on the levels of contamination that that PPE, excuse me, worn by healthcare workers would get? So contamination of PPE, a huge amount of disposed PPE and other healthcare waste is now overwhelming our waste disposal service. Any advice to improve the situation? Well, I can understand what's going on, and I know particularly in some parts of Vietnam, Ho Chi Minh City, there's a big outbreak. So any advice, Tom? Any thoughts on that? And
I think that I'll be honest, I haven't got the data in front of me or in my mind, so I'll have a look into that. But I know there have been some studies looking at contamination on PPE worn by healthcare workers. So I can try and dig out some references for that.
Okay. I think what we're going to do, Tom, after the webinar, we'll put, if it's okay with you, we'll put a PDF version of your presentation on the Project 81 website. And if there are any additional links that you might feel useful, we can put them on there as a kind of resource for delegates and actually anybody that needs to have a look at that. That would be great. Okay, thanks for that. Well, in terms of volume is a difficult one to manage. I don't think anybody's got any real solutions to volumes of PPE because we don't always have the capacity to deal with it. But let's see what advice is available, and we'll put that on the website. Okay, another question from Mati Padamasivam. How do we dispose of Virkon disinfected waste, since it's not advisable to autoclave it? What are the recommendations? Any thought on that, Tom?
So on site we actually do autoclave some Virkon waste, but it does say that I think Virkon loses its potency after 7 days, hence why you sort of make it up and you have a 7-day expiry period from when you either use the tablets or the powder. So it might be just a matter of leaving your Virkon disinfected waste for 7 days prior to autoclaving.
Okay, right. Thank you for that. And then.
But also we can limit the amount. You should really sort of limit the amount you're autoclaving as well. You shouldn't be looking to autoclave sort of liters and liters of it. So
yeah. Okay. Well, that's interesting. Yeah. Thanks for that. And then the final question on the Q&A line is from Ratigon Guntapong, and he is asking, could you please give me a comment whether it's acceptable or not to bring waste from the laboratory without our autoclaving and then leave it for outside contractor to manage somewhere outside the campus? And what should be done in this case? So I suppose it's the risks of material being disposed of without being autoclaved, actually. I think that's the bottom of that.
Yeah, so I know it's a difficult one, this one. So if you had the autoclave, then you should be using it prior to removing waste, especially obviously infectious waste from the lab, which is going to have a high concentration or potentially a high concentration of SARS-CoV-2. But obviously it's understandable that sometimes you don't have or the laboratory might not have the facilities to complete this, where you will employ an external waste contractor to undertake your waste management for you, or even you might just have a separate building from the laboratory where the waste actually or where the waste will be processed. So I've been to a few in sort of Southeast Europe and Eastern Europe, where they have a sort of autoclave or hydroclave room separated from their facility. So they have to transport waste there. So it's making sure that you have the appropriate containers for waste transport and waste storage. So there's going to be safe. It's going to be safe for people to handle, but also there's a very low risk for spillages or leakages to the environment and to the people actually handling that waste. But you really need to discuss the sort of waste management with your contractor and find out what they're going to do. But if that is how your facility does actually work, then obviously then you have to manage that risk through that in terms of waste treatment.
Okay, great, Tom. Thank you very much for that. We're almost out of time. I will just ask any of the panelists, particularly Sabai or Christopher, whether they want to add anything to that, and then we'll need to close. But just over to you if there's any observations you'd like to make.
Yeah.
Go on, Christopher.
Yeah, I mean, in the very first poll, it was interesting. Obviously, everybody had infectious waste as their primary concern, but I thought the chemical waste at PHE we did have. It was a concern for us given the high throughput nature of the diagnostic testing we were doing, and we were generating considerably larger amounts of chemical, so inactivated pathogen in the lysis buffers, large volumes of that. So that was something we had to deal with. And the other thing was sometimes the very buffers that we use to inactivate virus can react with bleach. So we have to be very careful because guanidinium thiocyanate, which is that active ingredient, will actually react with chlorine to produce a toxic hydrogen cyanide gas. So these are things we have to also be aware of when dealing with large numbers of sampling.
Right. Yeah. Thanks, Christopher. Very, very helpful. As I say, any thoughts on that? We can any other advice? We can put that on the website. Sabai, you wanted to have a quick word?
Yeah, I'm thinking about a lot about the waste because of I can see people in especially in the regions, healthcare sectors. I felt that they haven't moved out from the first phase of the pandemic because that time the science was not that strong, so people wrap up themselves very well. So they don't want to expose their skins by so I can understand that. But now the science is different, so they have to consider what kind of PPE they are going to use in the hospital setting, in the clinic and laboratories, because I know they are still using a lot of type suits, which are very expensive and then very bulky, and then how to decontaminate and then how to autoclave, those are very bulky things. So you have a lot of problem with the waste management. So I think I would like the laboratory and hospitals people think about how to streamline the PPE again, because now is the different phase. A lot of healthcare workers already have vaccinations also. So the PPE can be revised. That is my take from this talk.
Yeah, thanks, Sabai. And I think actually it goes back to the recommendations on waste management generally. The first step is reduce. How do you reduce? And looking at appropriate, minimizing the level of protection, but making sure that it's adequate for the person wearing PPE without generating a huge amount of waste. And Tyvek suits, as you say, expensive, bulky, and produce a lot of ash, I imagine, when they're on. Okay, look, we've got a couple of seconds left.